tendency for meet, and the most part of the head is in between your palms. If the head is engaged with larger segment into the pelvic cavity, you will have no possibility, your fingers will have no possibility for meeting. This part will have possibility to meeting, while the tip will diverge. Did you understand me? You will evaluate that the head is engaged into the pelvic cavity with large segment. If you will not palpate the head, but palpate shoulders, the head is on the pelvic cavity in whole. Understood, ma'am? Leopold maneuvers. Do you have questions?
Yes, ma'am. You're still on the left or the right side of the woman?
No special rule. No special rule. Mostly we are
Right.
on the right. It would be depend when is the wall. If it is just in the middle, you may stay on the left side, on the right side. If she is lying near the wall, you will do it. Or it may be dependent on your hand, left writing or right writing. Understood me? So we did 4 manual skills. And the last one, manual assistance for the head delivery to prevent perineal lacerations. I will explain it to you. Would you like, please, promise me that you will open the first volume obstetrics. You will open the chapter when it is explained the second stage of labor, management of the second stage of labor, and few sentences only. Very short explanation how to perform manual assistance. By the way, in practical workbook, you'll find it too. Just the same. So, what is the aim of manual assistance for preventions to prevent perineal laceration? It should be started with the starting of bearing down efforts. Not with the bearing down efforts, it should be started with the beginning of the crowning of the head. Do you know what is the crowning of the head? On the tip of bearing down effort. The leading point, together with surrounding tissue, neighboring tissues, will come out because it is leading point. Yeah, will come out on the tip of contraction. In between contraction, it will come back. Starting from this moment, you had to replace your left hand on the symphysis pubis. When the head appears, don't press, don't push, only close this area to prevent preterm extension of the head. If the head will perform preterm extension during the crowning and during the disengagement of the head, it would be delivered not with 9.5 cm of suboccipital rhegmatic, but would be delivered with suboccipital frontal diameter, which is already 10 to 10.5. It is not so good for the patient. To prevent laceration, we had to prevent preterm extension. Don't use tips of your fingers. In most of textbook, it is shown this moment, this on English replacement. When you use tip, you will use more forces. And when you will try to use this one, this surface, palm surface, it is not so forceful. Did you understand me, for example? So, not with the tip of fingers, but with your palm surface. I would like to perform bearing down efforts. Coming, then coming back. Yeah, on the tip of palpation. What I am doing, when she has breast in between palpation, I perform, when she come out, I will try to extend this perineum. Am I right? My English, I'm slightly tired. When the head is inside, let it be inside, lady. Wait me, please. My right hand here, and I had to perform boring, am I right, of the soft tissue. What does mean boring? I will try to push it down, to extend it and push down. Then come out When it is came out, I perform pretension of preterm extension, and my fingers are presses the boroid tissue to the ischial tuberosities. Did you understand me? Now, come out again. Yeah, sure. More. Here is disengagement of the head. What does mean disengagement of the head? Disengagement of the head means that biparatal diameter is already delivered, and head, even between contraction, has no possibility to come back. Did you understand me? In this position, from this moment, I had to wait when the suboccipital fossa will come into the direct contact. So again, I prevent preterm laceration, making boring and pressing on the tip of contraction. When the head shows suboccipital fossa and I see that it is fixed, the head will perform extension, revolving around the point of fixation, and in this case I will replace perineal tissue from the face and continue to press to the tubal issue. So, while you are making this maneuver, you have to pay attention to the perineal skin, appearance of light color, paleness, or redness, or thinning of tissue, or very small fissure-like overextension. Means all of them, or even the only of these signs, means threatened rupture of the perineum. You had to wait when she will present the tip of contraction at enter. Imagine that it is scissors. Do we have scissor here? No scissor. Enter it inside and on the tip of contraction. With one movement, make dissection of the perineum. Episiotomia or perineotomia or mesolateral episiotomia. Great mistake again and again. You repeat it. Episiotomia. Episiotomia means I will perform fossa, stomach. Did you understand? Episiotomia. Not laparostomia, but laparotomia. Did you understand me? So we made it. Main steps to prevent preterm extension, to make boring, and to push it to the ischial tuberosities, and to observe if she has or has no signs of threatened rupture of the perineum. Labor is finished. Head is delivered. Then you will wait. No, you should not show it during your final exam, but you will wait when the head will show how it would be rotate. When you ensure that it will be rotate, for example, to the right side, you will help to rotation, taking with this movement. Push it down to make delivery of the upper third of anterior shoulder. Then upward to deliver posterior shoulder. Enter your fingers on armpit and take it out. Labor is delivered. Do you have questions?
What are the commands for the mother? To breathe through her mouth during this.
When do you tell her to do that?
Mouth. Breathing.
Is it during bearing down or
Bearing down.
Exhale.
to exhale?
Yes.
You may control it.
Okay.
Because what does mean bearing down efforts? What is the difference? And I'm usually asking you during our practical classes, what is the difference in labor pains in the first stage of labor and labor pains in the second stage of labor. Labor pains in the first stage of labor are only contractions of smooth muscles, uterine contractions. Labor pains, which are in bearing down efforts or expulsive pain, means contractions of uterine muscles, which are smooth muscles, contractions of diaphragm, and contractions of the legs, hands, and perineum. These contractions of skeletal muscles may be regulated. If you need, for example, she pushing down, but you find that there is sign of threatened rupture, you will tell your patient to perform very deep in breath, very fast breathing, to slightly arrest contraction, to enter scissors, and to make incision. Or disengagement, head is coming, and you will tell her to make breathing, to perform pressure, to, how in English, slide the perineal muscles from the fetal head and so on. If you need, you will do it. If it is normal, you will not do it. Only follow your contractions. Do you understand me? And it would be dependent on the intensity of contraction, and mostly would be dependent on the fetal head and rigidity of these muscles. Primipara, multipara. If the head is smaller, slightly smaller, or slightly bigger, it is possible to deliver for this head, but it may lead to rupture. Or your patient may have already scar. You had to rest your bearing down effort to ensure if it is extendable, or you had to perform incision.
What if the fetus is in transverse lie and you want to do the first Leopold maneuver? What will you say when you come?
So, in case of transverse lie and first Leopold maneuver, you will not find here now cephalic, now pedalic, empty space. And be sure that it is term pregnancy at 38 weeks, for example, but the significant will be
less than the gestation age.
But you will not perform only first Leopold maneuver. If you didn't find, you will slide over and in transverse position. On one side, you will find the head. On another opposite side, you will find the bridge. And auscultation of the fetal heart sound. If it is cephalic presentation, it would be depending on the position to the right or to the left, lower than the umbilicus. In case of bridge presentation, depending on position, upper. In case of transverse, just level of umbilicus. To the right or to the left, depending on the head. In transverse position, in transverse line, position is defined according to the fetal head. If the head turned to the left, it is the first position. If the head turned to the right, it is the second position. And in this case too, back may be turned anteriorly, back may be turned posteriorly, thus may be anterior type of position, posterior type of position. In vaginal exam, you will not find presenting parts. It is very high, no presenting part. And you will palpate with your external hand, so cephalic hand, which is located in the lateral. Yes, transverse. Any other questions? In multiple gestation, you will find, for example, here head and here the head. Understood me? And two types of fetal heart sound. We did it. We made auscultation of the fetal heart sound. One would be 140, another maybe 155. Different places, different rate. Understood me? In case of triad, tetrad, and so on, you will understand that it is free head, for example, are not understandable. Fortunately, we have possibility to make ultrasound exam and CTG. Russians.
Excuse me, ma'am, please, can you give the prescription for magnesium sulfate in eclampsia?
You still don't know it?
I know it now, but I just
So,
want to
magnesium
confirm.
sulfate, 25% solution. Bolus would be entered with a syringe within 15 minutes. You will take 16 ml of magnesium sulfate plus 34. In summary, it would be 50 ml. And enter with a syringe slowly within 15 minutes. It is bolus. Then you will take 120 ml of isotonic solution and 220 ml of isotonic fluoridated isotonic solution and 30 ml of 25% solution of magnesium sulfate. Pay attention, 25%. This prescription is for 25%. Did you understand me? And summary, it is 250. Here is summary 50. Understood me? 16 plus 34. And it should be entered slowly. Maintenance. Intravenously. Droppingly. 1 gram per hour means 11 drops per minute.
Let the woman talk with her. I asked her the question.
Да. Какую-нибудь тему дайте заниматься. Преждевременные переношения.
This bolus, is it the one we'll give on each Botox? Or
No, one Botox intravenously, slowly with a syringe.
yeah,
In the internet, it is written to each buttons.
Yeah.
Don't use it in the internet. You may get very great, big, and good information. On the other hand, it may be incorrect information. So, by protocol, it is not used into the buttocks. It is used maintenance bolus intravenously with a syringe very slowly. Did you understand me? And then you will continue. You will not take the needle from the vein. You will enter, как это называется, connect капельница and continue maintenance. And ladies already told, depending on them, среднее артериальное давление, middle arterial pressure, you will enter with 1 gram per minute means 11 drops per minute, 2 gram per minute, 22 drops per minute, 3 gram per minute, 33 drops per minute. Understood? Don't even try to, maybe in your practice you will use into buttocks. We have a lot of schemes of usage of magnesium sulfate, but WHO protocol present only this one. That's why it is used all over the world. And the same would be used for tocolysis, for treatment of preterm liver. Что-то я хотела еще сказать. Just now.
I have it. Okay. You're contradicting. I have a lot of material information. So
Other
I
versions.
heard that she said no Botox anymore. I wanted to confirm. Even on internet, like Botox.
We don't use it in buttocks because everything which is used for treatment of patient with preeclampsia especially should be used intravenously because it is emergency. You understand me? Everything which should be used in labor principally should be used intravenously because it is emergency. What I wanted to tell. In some countries, maybe 50% solution of magnesium sulfate. In this case, you will take 8 ml, yeah, and half of dose of isotonic solution.
So half.
But only in Malaysia.
8 ml plus 18.
Only in Malaysia, so it's. Did you understand me? In some Malaysian protocol, we use 8 ml and half, yeah. Не засоряйте себе мозги. 16 plus 34.
25.
It means 4 grams of dry substance of magnesium sulfate. You may tell 4 grams, but I will ask you, would you like to take 4 grams of dry magnesium sulfate from 25% solution? If you know this mathematical formula and will show it to me, I will be proud. If you will not show it to me, yeah, it will be a mistake. Because when you will come to the hospital and you will need to enter it, you will have no possibility to use mathematical calculate. You have to learn it, you have to remember without on English, thinking and memorizing. 16 plus 34. No questions? Or you have any other questions? Don't be afraid, please. You worked hard. You worked within the 6 years. You have your own knowledge. And you had to win your emotions. If you will be able to win your emotions, your knowledge will come to your brain themselves. Did you understand me? Without your trying. Understood? And try to imagine that you're a real doctor. Try to be to this, to play this game. I'm doctor, what should I do? You will concentrate just from the very beginning and you will be able to get correct answer. Even if you will give incorrect answer, we are not your English enemies. I can answer some question, give you some question, additional question, push you to understand what is your mistake. You will have possibility to come discuss this problem with your examiner. On one hand it is difficult, on another hand it is easy, because examiner is not machine which is find what is the correct or incorrect answer as it was in drop. Examiner is real person which have possibility to discuss and understand what are your knowledge. Maybe you had a mistake, you made a mistake. Everybody may have mistake and nobody is perfect. Even when we are very experienced doctor. But you have possibility to improve your answer. Well, you will discuss it with your examiner. You will have possibility to try to prove why you decided that this, your diagnosis is correct. Maybe it is correct. Maybe you will prove it. So don't be afraid. But I ask you, please, within the last year, when our students have practically oriented exam, last year students, they even didn't try to prepare. They, in English, saved these tasks into their iPhone, and try to read it, rewrite it. No. If you respect yourself, then, please, try to repeat, try to show your knowledge. Let it be, surprising. Yeah, because when our students give us a correct answer, we are so happy, we are so proud, and it would be our last day together. That's why, would you like to repeat some main questions? Would you like to prepare for exam? Understood me? Yes, ma'am. If you have no question, when we will meet at 4th or 3rd? 3rd? Хорошо. At 3rd of June, next Monday, 7:30, железнодорожная больница. I will wait you. Via Phantom. If you have no questions, you may be